Good evening, everyone. I am Dr. Keerti. Today, me and Manishikaa will be presenting a topic on the review on the landmark trials in the management of neovascular age-related macular degeneration. ARMD is the most common irreversible cause of vision loss in the developed world. There are two distinct forms of ARMD, the wet form and the dry form. The wet form accounts for 10 to 20% of the total patients with macular degeneration. Not a particular etiology has been discovered, and the causes of ARMD have been speculated to be due to excessive oxidative stress, immune hyperreactivity, dietary deficiencies, age, smoking status, and heredity also appear to play a role. So these are the trials which we'll be talking about today. Ranibizumab and bevacizumab I'll be covering, and the remaining things will be talked about by Dr. Manshika. Coming to ranibizumab. Ranibizumab is a monoclonal antibody fragment directed towards all isoforms of VEGF-A. It has a molecular weight of 48 kilodaltons, thus being a small molecule has a greater retinal penetration with less antigenicity. It lacks the FC region of the antibody, hence it's less likely to cause a complement-mediated inflammation post-injection. Ranibizumab has only one binding site for VEGF, whereas bevacizumab has two. It is predicted that the ranibizumab half-life in vitreous is around 9 days, and US FDA approved it in 2006. We should remember that these trials they aim to see the stability of the vision maintained throughout the study and not upon the visual gain. These trials are mostly due to improve and optimize the vision. The trials with the fixed regimens include Marina, Anchor, Pier, and Excite. The trials with the flexible regimens are Pronto and CAT. So, what are superiority trials? When the aim of randomized control trial is to show that one treatment is superior to another, it's called a superior trials. Coming to our first trial, this is the Anchor trial. So the first question arose was whether ranibizumab would lead to reduced vision loss and improvement in vision. So Anchor is a phase 3 trial with a period of 2-year duration with the 3-arm study. It was designed to evaluate the efficacy and the safety of monthly intravitreal injections of ranibizumab when compared to sham photodynamic therapy. It recruited around 423 patients with predominantly only classic CNVM across multiple centers around US. Patients were randomized in 3 arms, one being monthly zero point 0.3 milligrams, second one ranibizumab 0.5 milligrams, and the third one PDT protocol plus sham injections. The primary endpoint was the best corrected visual acuity, which was patients losing fewer than 15 letters per EDTA from baseline. The inference showed that approximately 94 to 96% of the patients, when we see this graph, the first one, anchor graph. Okay, so this graph is mostly depicting the best corrected visual acuity against the time period which was done, that is for 2 years. So the patients who took ranibizumab had a visual acuity improvement of around 10.7 ETDRS letters, and the ones who were with the sham, they had a 9.8 letters loss of visual acuity. So this was done in Anchor, and this was the inference. Hence, ranibizumab, it proved a greater clinical benefit than photodynamic therapy. Coming to Marina trial, this trial was designed to determine the efficacy and the safety of ranibizumab in the treatment of minimally classic and occult neovascular ARMD. It is also a phase 3 trial, which was done for a period of 2 years, and it is a 3-arm study. The inference we found that was 95% of the 95% of the patients had a visual acuity which was improved up to 6.6 ETDRS letters, and it was stably maintained throughout the 2-year period. Whereas the people who had a sham had a decrease in visual acuity of around 14.9 ETDRS letters. These were the superiority trials. The takeaway points from these both trials were that ranibizumab prevented vision loss and disease progression, but the long-term effects of ranibizumab were still uncertain. Post this, following Anchor and Marina, several studies looked to see whether disease treatment burden could be decreased by producing the same visual gains. So these studies were Pier, Excite, Pronto, Sustain, and Horizon. So coming to the next, view 1 and view 2 will be covered in detail in the next slides. Coming to our next studies, Ivan study. So, what are first non-inferiority trials? Non-inferiority means an investigational treatment is not worse than the standard of care or the comparator by a small amount. That margin can be called either a delta margin or a non-inferiority margin. So, Ivan is a trial which was designed to compare these drugs like bevacizumab and ranibizumab across different regimens. So the question arose whether bevacizumab was non-inferior to ranibizumab, and they took a non-inferiority limit of around 3.5 letters. And visual acuity was assessed at the end of 2 years. And in addition to this, Ivan also studied with the patients with arterial thrombotic events also was studied. So patients were randomly assigned to 4 arms, like ranibizumab 0.5 milligrams in a continuous dosing, that is every monthly dosing, or a discontinuous dose, and bevacizumab 1.25 milligrams in a continuous or a discontinuous dose. The inference they showed that both ranibizumab and bevacizumab had a similar letter or visual acuity gain at the end of 2 years. The lesion size, the retinal thickness, and the adverse effects or thrombotic events were equal for both ranibizumab and bevacizumab. And also, the letter gain was equal for both the monthly regimen and the discontinuous, that is, both continuous and discontinuous. Then came the peer study. The peer study was to determine the efficacy and safety of ranibizumab monthly for 3 months and then a quarterly dosing. This trial it aimed to produce visual acuities and compared them with the superiority trials, that is with Anchor and Marina. And the inference was the treatment effect declined during the quarterly dosing, and it was less when observed when compared to Anchor and Marina. When compared to prolonged long monthly doses, maintenance quarterly doses appear to be less effective. The 12-month efficacy of peer showed that both 0.3 and 0.5 milligram ranibizumab injections provide statistically significant superiority in visual acuity improvement. Then came the EXCITE study. This was to demonstrate the non-inferiority of a quarterly treatment regimen to a monthly regimen of ranibizumab in patients with subfoveal CNVM. Patients were randomized into 3 arms, 0.3 milligrams quarterly, 0.5 milligrams quarterly, or 0.3 milligrams monthly of ranibizumab. The best corrected visual acuity and the central retinal thickness and the adverse effects were assessed. At month 12, the best corrected visual acuity gain was seen mostly in the monthly regimen than in the quarterly regimens. The non-inferiority of the quarterly regimen was not achieved because the reference was only 5 letters. The safety profile was similar to that when reported to ranibizumab studies. Coming to SUSTAIN study. Before we come to SUSTAIN study, what is PRN? PRN is nothing but pro-re nata, that is as per when needed. So, for example, like if the disease is there, then only these patients were treated. Like, for example, if a fresh subretinal hemorrhage or a visual acuity loss of less than 5 letters, or if OCT showed increased thickness or increased fluid, then only these patients were treated. And these patients were asked to come monthly. This is PRN treating, and this is PRN. So, SUSTAIN study, what it was is to evaluate the safety and efficacy of individualized ranibizumab treatment in patients with ARMD. There were 3 initial monthly injections of ranibizumab, 0.3 milligrams was given, and thereafter pro-renata PRN treatment for 9 months, depending on the specified retreatment criteria. Sorry. Okay. Thereafter, after the retreatment criteria, the frequency of adverse effects, the best corrected visual acuity, and CRT were measured from baseline, and the inference was the mean BCVA or best corrected visual acuity, it steadily increased from baseline up to month 3 because it was monthly dosing. Then from month 3 to 6, it slightly decreased, and then it remained stable from 6 to 9 months. The mean change in the central retinal thickness also decreased from 101 mu meters to 91.5 mu meters up to month 12, and the safety results were comparable and favorable tolerability profile of ranibizumab in the previous pivotal clinical studies was observed. Coming to Horizon study. Horizon study is an extension study. Patients who were in Anchor and Marina who had undergone a 2-year study period, they were further studied for another 2 more years to see the long-term efficacy of ranibizumab. So this was a 2-year extension of the patients taken from Marina, anchor, and focus was taken, and the efficacy of multiple intravitreal ranibizumab injections was assessed. They were divided into three groups. First group, patients treated with ranibizumab in the initial study. Then the second group, patients randomized to control who have crossed over to ranibizumab. Third one are naive patients who have not ever taken ranibizumab. So 0.5 milligrams was administered at the investigator's discretion, meaning when the doctor felt like he wanted to give, then only he had given. Adverse effects and BCVA assessments were conducted at the study every 3 to 6 months. Inference showed that it required significantly fewer injections, and the PRN usage of ranibizumab after an intensive period of treatment were able to maintain the visual acuity gains. At around month 48, that is around 2 years, the mean change in the BCVA in the initial study was around 2.0 in the ranibizumab treated group versus 11.8 in the pooled ranibizumab group. And the outcome finally was ranibizumab was well tolerated over 4 years with less frequent injections and decline in visual acuity gains. Then came the question of whether ARMD could be treated with ranibizumab only using visual acuity and OCT. The answer was yes. The study was PRONTO study. PRONTO is nothing but prospective OCT imaging of patients with NARMD treated with intraocular ranibizumab. This was done for investigating the efficacy of intravitreal Lucentis given monthly for 3 months, then followed by an as required dosing regimen guided by clinical and OCT appearances. Patients were given 3 consecutive monthly injections with ranibizumab. Subsequently, from month 3 to 24, patients were examined with OCT and every 3 months with angiography. The main efficacy endpoints were the change in the visual acuity and the retinal thickness. The inference showed that there was a mean improvement in visual acuity score from 10.7 letters with a mean reduction in the central retinal thickness on OCT of 215 μm. So the first graph, this graph shows the visual acuity. So earliest detectable changes were started from day 14. That is, the visual acuity gain had started from day 14, and they gradually kept increasing up to our 1 year period. And then they remained stable over the course of another year, which was up to 9.6 letters. And the improvement in the visual acuity was seen with the decrease in the central retinal thickness. We cannot say it's directly proportional, but the improvement in the acuity showed the decrease in the retinal thickness. So it finally came up to 211 μm by the end of 2 years. This was the PRONTO study. And then the SAILOR study. SAILOR was basically for the safety assessment of intravitreal Lucentis for ARMD, which was a phase 3B follow-up study to MARINA and ANCHOR studies. This was for the long-term safety and efficacy of ranibizumab in a larger population of subjects with all subtypes like minimally classic, occult with classic, occult without classic, or neovascular ARMD. There were 2 study cohorts which were enrolled. The first cohort were randomized to receive either 0.3 or 0.5 intravitreal ranibizumab, and the rates of the ocular side effects were noted. The second group received an open label 0.5 milligrams intravitreal ranibizumab. The incidence of the non-ocular adverse effects were potentially related to anti-VEGF therapy. It was very low and comparable across all the cohorts and the dose groups. So all the dose groups at the end of the study, they showed visual acuity which was increased in the first 2 to 3 months, and then it gradually decreased in 3 to 12 months. The central field thickness, which decreased in the first 3 months and it was stable around 6 to 12 months. Because the study did not include a control arm, safety could not be evaluated in terms of events related to ranibizumab treatment, and thus this was the limitation of this study. Coming to HARBOR. HARBOR is the study of ranibizumab administered monthly or on as an PRN in patients with subfoveal ARMD. It was a 2-year study on ranibizumab, and this analysis was Subjects were randomized to receive ranibizumab 0.5 milligrams and 2 milligrams monthly and or on PRN basis. All the groups demonstrated visual acuity improvement and anatomical outcomes. The PRN group, it required approximately fewer injections and no additional benefit with 2 milligrams was noted. Then came the treat and extend. So the question arose whether ranibizumab in treat and extend was safe. and effective as per monthly. What is this treat and extend? So treat and extend is when the patient has a disease and he took the treatment, but and post that he achieved full visual gains, not full, but at least maximum visual gains, then these patients were subject to elongate the interval between the injections to maintain the stability, and then they were called up like after 6 weeks. That visit after 6 weeks was a mandatory visit. So irrespective of the activity, whether they had it or they hadn't it, but they were supposed to come after that 6 weeks fixed period. This was mostly aimed to improve the patient's compliance. So this is T&E treatment, treat and extend. This was the trend study. The primary objective of this study was to demonstrate the non-inferiority of ranibizumab 0.5 milligrams T&E regimen versus the monthly regimen. Subjects were randomized to receive 0.5 milligrams using the T&E protocol or the monthly protocol. And the result, what they found was T&E regimen was non-inferior to the monthly regimen with a mean BCVA change of baseline. So I'll tell you in the graph. So this is the graph which shows first the improvement in the visual acuity. So the ranibizumab patients which were taken on a T&E regimen is this dark black line, and the one who had taken on a monthly regimen. So the people who had taken this on a monthly regimen showed a gradual improvement in visual acuity, and it was stable throughout the 1-year period. Whereas the patients who had taken it on a treat and extend protocol also showed the similar visual acuity, but a little less when compared to that of the monthly regimen. And the same was seen in the central retinal thickness. Both were around the same thing. Central retinal thickness showed a decrease, and it was around the same figures, around minus 173 for the monthly regimen and minus 169 for the regular. By the end of this, we concluded that it required less visits and lesser injections were required. These are the references for ranibizumab. I would like to conclude ranibizumab by saying that by the end, Anchor, Marina, View 1 and View 2 advocated the monthly usage of ranibizumab, whereas Pronto, CAT and I1 studies, they were the proponents of PRN, which is also equally effective. Coming to bevacizumab, it is a recombinant humanized monoclonal Ig1 antibody that binds and inhibits VEGF-A. Its molecular weight is 149 kilodaltons, and it has 2 binding sites per molecule. Both ranibizumab and bevacizumab are equally potent at binding to VEGF. It has a longer half-life than ranibizumab, that is around 20 hours. That's why it persists longer in the eye. The systemic adverse effects may be due to the systemic absorption, which is also higher for bevaz, and it has a longer half-life. The dose scheming may be also longer, and hence the longer interval of injections. First is the CAT trial. The question arose whether bevacizumab was non-inferior to ranibizumab. CAT trial is a multi-center randomized, double-blind, controlled clinical trial which was randomly assigned to the 4 arms. The 4 arms being bevacizumab 1.25 milligrams given either monthly or a PRN dosing versus ranibizumab 0.5 milligrams given monthly or a PRN dosing. The results show that in efficacy, the vision was same in between bevacizumab and ranibizumab when the dosing regimens are same. The gain of the vision, however, was more for monthly when compared to PRN. Drying in the OCT was also seen mostly for monthly and mostly for ranibizumab when compared to the later. Adverse events. Monthly geographic atrophy was mostly seen in the monthly regimens, whereas systemic side effects mostly were seen in bevacizumab when compared to ranibizumab. Cost effectiveness, ranibizumab is very costly, thus causing a 40-fold increase in the economic burden. And since the OCT drying is more for ranibizumab, bevacizumab required 1.5 injections more when compared to ranibizumab. This is illustrated in the form of this graph. All the 4 arms of the study showed an equal increase in the visual acuity gains, which was seen, but mostly monthly, the blue darker line had a higher raise in the visual acuity by 8.8 ETDRS letters. This is the last trial, Lucas trial. This is according to treat and extend protocol. The study was mostly again for bevacizumab 1.25 versus ranibizumab, according to a treat and extend regimen. The efficacy showed that the primary outcome measure, endpoint BCVA, was equivalent to that of ranibizumab. The secondary outcomes were the number of injections. It was more for bevacizumab when compared to ranibizumab. A reduction in the central foveal thickness was more for rani when compared to bevacizumab. Intervals between the injections was more for bevacizumab when compared to ranibizumab. The adverse events like arteriothrombotic events also were noted, which was seen more for ranibizumab when more compared to bevacizumab. Treat and extend protocol, there were 8 visits monthly, had 12 visits. The rest of the slides will be continued by Dr. Manishikaa.
Good afternoon, everyone. I'll continue with the rest of the slides. At the end of the previous talk, it has the questions answered was about the treatment posology. Monthly is better than PRN, and treat and extend regimen is non-inferior to the monthly dose. And between this ranibizumab and bevacizumab, ranibizumab has though both has a non-inferior visual gains, but ranibizumab has lesser systemic side effects with better OCT drying. A quick recap of the molecular structure of the bevacizumab is already explained. It has a FC portion and a FAB portion. It's a recombinant humanized monoclonal antibody. The FAB portions binds to the VEGF targets, and the FC portion, it binds to the endothelial cells, and because of the binding of the FC portion, and it gets also recycled, so it stays in the body for a longer time, which causes the systemic complications. Ranibizumab has only the antibody fragments, the FAB portion alone, and it has a greater surface area, and it has better affinity to VEGF. Coming on to aflibercept, the FC portion is same as that of bevacizumab, but the FAB portion is a decoy fusion protein. That is, it resembles or mimics the VEGF receptor, which is present like in our endothelial cells. So it binds all VEGF A forms and VEGF B, and also placental growth factor, it also binds to them, so it is also called a VEGF trap. Coming on to brolucizumab, it is the smallest molecular weight among all the anti-VEGF. It's 26 kilodalton, and because of this, it can achieve a higher molar concentration in RP and neurosensory retina, which is twofold more than the ranibizumab. And coming on to faricimab, it has a modified FC portion, and this modification has been done to reduce the intraocular inflammatory events caused by other anti-VEGF, and it has two arms. It's a bispecific antibody. It targets anti-VEGF A isoforms and also angiopoietin 2. This is a newer molecule, another molecule, OPT302. It has a target to VEGF-C and VEGF-D, and it is given along with the VEGF-A acting anti-VEGFs. Coming on to the aflibercept trials, View 1 and View 2. It's a non-inferiority trial, meaning the new drug or the new treatment posology is not worse than the standard of care treatment. In View 1 and View 2, it compares ranibizumab 0.5 milligram 4 weekly after initial 3 loading doses versus aflibercept 3 groups, 0.5 milligram 4 weekly, 2 milligram 4 weekly, and 2 milligram 8 weekly. The doses are given in the first year. In the second year, it is capped. It undergoes a capped PRN regimen in which the patient has to come every monthly for their follow-up. But irrespective of the visual outcome or the functional outcome, they'll receive injection at the end of 12 weeks. Efficacy is non-inferior to ranibizumab, and but the outcome measure in terms of OCT drying is more with aflibercept. The durability is more for aflibercept because it has number of injection is less, fewer visits, and greater improvement in quality of life. The adverse effects of aflibercept in View 1 and View 2 is comparable to ranibizumab. In fact, it is less 0.1 events per 1000 injection compared to 1.1 events of ranibizumab. Coming on to Pulsar trial. Pulsar trial gives a four-fold increase in aflibercept, that is 8 milligram aflibercept given 12 weeks and 16 weeks interval dosing versus 2 milligram aflibercept. The efficacy is that the visual gain is non-inferior to 2 milligram, and the outcome measure is better for 8 milligram aflibercept compared to 2 milligram. The durability more than 50% of the patient are able to maintain their interval dosing of 12 weeks and 16 weeks. 8 milligram aflibercept has a similar adverse events compared to 2 milligram aflibercept. These are the real world outcome study. This is not a trial, it's a study, the Atlas study and Rival study. They employed a treat and extend regimen. In Atlas study, aflibercept is given 2 milligram after the initiation doses, and the visual gain is comparable to all anti-VEGF. That is 7 letters, which is comparable to the treat and extend regimen in Lucas to bevacizumab and ranibizumab. The durability is also more for aflibercept, and the adverse events, they have shown fovea involving geographic atrophy, which is like that of CAT trial. Rival study, it compared treat and extend regimen for ranibizumab versus aflibercept. The visual gain is comparable to ranibizumab and aflibercept is 5.2 and 6.9. And the durability, the number of injection is similar in both of these. This is another molecule which is similar to aflibercept, zif-aflibercept, but the buffer solution which used for zif-aflibercept is more, and it is also cost effective. This Zebra trial compares zif-aflibercept versus control, which is the patient is allowed to continue the previous anti-VEGF regimen. But at the end of the follow-up, both the control and zif-aflibercept, they didn't show any improvement in visual gain. So even though they have a trend towards decreasing CFT, but it's not statistically significant. Coming on to brolucizumab, the main Hawk and Harrier trial. Here in the Hawk arm of the study, they compare 3 milligram and 6 milligram brolucizumab with the aflibercept 2 milligram. And brolucizumab is given 12 weeks and 8 weeks regimen according to the disease activity assessment in 20 weeks, 24 weeks, and 28 weeks. If the patient has disease activity in any of this, they'll reduce the interval, that is to 8 weeks. Efficacy, the visual acuity is non-inferior to aflibercept, but the anatomical outcome, OCT drying of brolucizumab is more compared to all other anti-VEGFs. And the durability, they are able to, more than 75% of the patients, they are able to maintain a 12-week interval, which reduce the treatment burden for this patient. The main concern with brolucizumab is the adverse events. That is the intraocular inflammatory events. In Hawk, 6 milligram brolucizumab, they reported a 4.7% of intraocular inflammatory events. And from those adverse thromboembolic events, especially retinal artery occlusion, it's about 1.4% in Hawk and 1.6% in Harrier. But all retinal artery occlusion patients had a concomitant comorbidities like cardiac arrhythmias and hypertension, and most of them showed a prior intraocular inflammation prior to RAO. These are the real-world outcomes of brolucizumab. Seeing on to the adverse effects, it is lesser compared to what showed in Hawk and Harrier. It is less than 4%. And only REBA study, which is German study, showed one case of retinal occlusive disease. Other or minor intraocular inflammation, which are treated conservatively. Braille study is an Indian study which included 127 patients, which had both treatment in switch and treatment naive patients. In switch patient, they noted significance, but in treatment naive, they didn't note any significance because of a ceiling effect. That is, the patient at the baseline visual acuity is better. So at the end of the treatment, they didn't get a significant visual gain. The OCT drying is they have a better OCT drying in all the studies, and the durability is more than 50% or more than 50 to 60% of the patients, they maintain their durability. Coming on to faricimab, as I had already told, it's a bispecific antibody which affects a VEGF-A or isoforms and angiopoietin-2. Angiopoietin-2 is a molecule which destabilizes the vascular structures, and also it is expressed more in neovascular tissue. So blocking this helps in reducing the neovascularization. There are 3 trials. First is the STARWAY trial, which compared faricimab 12 weeks, 16 weeks dosage, interval dosage with ranibizumab. And the visual gain is comparable in all 3. That is 9.6 in ranibizumab. Faricimab is 10.1 and faricimab is 11.4. The OCT drying is comparable and the durability is more than 60%. They are able to maintain. Adverse effect, The intraocular inflammation is nil for ranibizumab, but there is a 4.2% and 3.2% intraocular inflammatory events, but these are also minor events only. Tenaya they compared 6 milligram faricimab with aflibercept 2 milligram, and the visual gain is comparable with a better comparable CFT reduction, but the durability is superior to aflibercept. They also had a minor intraocular inflammatory events. Avenue trial, they compared ranibizumab 0.5 milligram 4 weeks and faricimab 1 milligram 4 weeks with 6 milligram interval 4 and 8 weeks. The visual gains are comparable in all arms, although not statistically significant. BCVA outcomes in arms receiving faricimab 6 milligram and 8 milligram are slightly lower, but it's not statistically significant. And OCT drying is comparable in all the arms. There are no reported serious adverse effects with this trial. This is a superiority trial which included OPT 302. It is under phase 3 clinical trial. As I already said, OPT 302 acts, it targets VEGF-C and VEGF-D, so it has to be given in combination with other anti-VEGFs. So they are giving ranibizumab with OPT 302 and with sham, and they have in a short trial, and aflibercept with OPT and aflibercept with sham, and they have found that the visual gain is more superior, plus 5.7 ETDRS letters at the end of 24 weeks. And they also have a safety, comparable safety profiles with monotherapy. Coming on to the failed trials, anacortive acetate, this is a cortisone which has angiostatic property, but it's devoid of glucocorticoid property. The purpose of the study was to demonstrate that anacortive acetate for depot suspension is safe and effective in arresting progression of non-exudative. Injection is given in a dry eye, dry ARMD, who are at risk of progressing to exudative ARMD. Dry ARMD patients are in the study eye, and the wet ARMD patient is a non-study eye. 0.5 milligram of the drug is given at the posterior juxtaslateral depot, 6 monthly interval. This study is terminated at the interim analysis because they didn't find any plausible difference between the sham and the study group. Pegclinidenib is a modified DNA aptamer which targets platelet-derived growth factor. Platelet-derived growth factor plays an important role in recruiting the pericytes. This also, the trial also terminated because there is no statistical visual improvement at the end of the interim analysis. So the take-home message, the questions answered was a treat and extend regimen is non-inferior to monthly regimen, even though monthly regimen is better in producing a better visual gain. The choice of anti-VEGF depends upon many factors, one being VEGF, which is comparable in all the VEGFs. But OCT drying is better for brolucizumab and aflibercept compared to bevacizumab and ranibizumab. The OCT drying is independent of the visual gain. The safety is better with safety is better with ranibizumab and aflibercept, and the bevacizumab showed some systemic complication, and brolucizumab had an occlusive vasculitis. The durability, it's more for brolucizumab and faricimab, around 12 to 16 weeks. Thank you.